What if the conversation you've been avoiding with your doctor about your erections is actually the conversation that saves your life? Not your sex life, your life. Most men who walk into a urologist office embarrassed about erectile dysfunction walk out with a prescription. A smaller number walk out with a referral to a cardiologist, and that referral, for some of them, arrives just in time. Stay with me for the next several minutes, and I'll show you exactly how to tell the difference between an erection problem that is local and manageable and one that is your cardiovascular system sending you the most urgent signal it knows how to send. I'm Dr. Jocelyn, a board-certified urologist with over a decade of clinical experience in men's sexual and cardiovascular health. I work closely with cardiologists because the overlap between what I treat and what they treat is not incidental. It is biological and direct. Today, I'm going to walk you through the science of how erectile function and heart health are connected at the vascular level. What specific patterns in your symptoms tell you which system is primarily involved, and what to do and say at your next physician visit to make sure nothing gets missed. The connection between erectile dysfunction and cardiovascular disease is not a correlation that researchers stumbled upon. It is a predictive relationship, and the numbers are serious. A landmark meta-analysis published in the Journal of the American College of Cardiology, synthesizing data from 92,757 men across 14 prospective studies, found that erectile dysfunction was associated with a 44% increased risk of cardiovascular events, a 62% increased risk of heart attack, and a 39% increased risk of all-cause mortality, independent of traditional cardiovascular risk factors like smoking, hypertension, and cholesterol. Independent, meaning erectile dysfunction itself carries predictive weight beyond everything else your doctor is already measuring. Today, I'm going to explain exactly why that relationship exists, how to read your own symptoms, and what the timeline looks like. Because for men over 55, understanding this connection is not optional. It is urgent. If your cardiologist and your urologist have never spoken to each other about you, hit that like button right now. Leave a comment telling me your age and whether your doctor has ever connected your erectile health to your heart health in a direct conversation. Because I want to know how often this link is being communicated to the men who need it most. Subscribe to this channel because we cover the intersections of men's health that individual specialists too often leave in the gap between their offices. And we do it every single week. Let me give you the biological foundation, because everything else in this video depends on understanding one central mechanism. Your cardiovascular system and your erectile system share the same infrastructure. They are not parallel systems that happen to both involve blood. They are the same system, the endothelium, expressing itself in two different locations. The endothelium is the single-cell thick lining of every blood vessel in your body. It is, collectively, one of the largest organs you have. If laid flat, it would cover the surface area of 6 tennis courts. Its primary job is producing nitric oxide, the signaling molecule that tells smooth muscle in vessel walls to relax, allowing blood to flow freely. Endothelial dysfunction, the deterioration of this nitric oxide-producing capacity, is the foundational event in both erectile dysfunction and cardiovascular disease. They do not merely share a risk factor, they share a cause. Here is why this matters clinically. The penile arteries are approximately 1 to 2 millimeters in diameter. The coronary arteries that supply the heart are 3 to 4 millimeters in diameter. When endothelial dysfunction begins reducing blood flow across the body, the smallest vessels are affected first. The penile arteries, being among the narrowest in the circulatory system, show functional impairment before the coronary arteries do, often by 3 to 5 years. This is the mechanism behind what cardiologists now call the artery size hypothesis. Erectile dysfunction, in a man with no other obvious cause, is frequently the earliest detectable clinical manifestation of systemic endothelial disease. A 62-year-old patient of mine came in for a routine urology visit and mentioned, almost as an aside, that he'd been having increasing difficulty with erections over the previous 18 months. He had no chest pain, no shortness of breath, no diagnosed cardiovascular condition. I referred him for a cardiac workup. His stress echocardiogram revealed significant coronary artery disease. He had a stent placed 4 months later. He has told me since that he is certain the urology visit saved his life, because the cardiac symptoms, by the time they arrived, would have arrived as a heart attack. Now let's talk about how to read your own pattern, because not every case of erectile dysfunction is a cardiac warning sign, and understanding the distinctions is what allows you to ask the right questions. The first dimension to understand is onset pattern, how your erectile difficulties began and how they have progressed. Vasculogenic erectile dysfunction, the type driven by impaired blood flow, which includes cardiac origin cases, has a characteristic onset pattern that is distinct from psychogenic, hormonal, or neurogenic causes. Vasculogenic ED develops gradually. It does not appear overnight. Men describe it as a slow erosion, erections that were once reliable becoming less firm over months, then years, then inconsistent, then absent. The progression follows the underlying vascular deterioration. As endothelial function declines and arterial plaque accumulates, blood flow capacity diminishes incrementally. If your erectile difficulties began suddenly, following a specific event, a period of stress, a medication change, or a relationship transition, the cause is far more likely to be psychological or hormonal than vascular. Sudden onset argues against a cardiac origin. Gradual onset over 12 months or more, particularly in a man over 55 with any cardiovascular risk factors, argues strongly for vascular investigation. The second dimension is the status of your nocturnal and morning erections. This is the single most diagnostically useful question I ask in a urology consultation, and it is one that men rarely think to report. During REM sleep, healthy men experience spontaneous erections driven entirely by autonomic nervous system activity. No psychological arousal, no external stimulus. These nocturnal erections are powered by the same nitric oxide mechanism as waking erections, but they bypass the psychological and hormonal pathways entirely. If a man is experiencing erectile difficulties during waking hours, but continues to have firm, consistent morning erections, this pattern points strongly toward a psychogenic or relational cause rather than a vascular one. The plumbing is working. Something upstream in the psychological or hormonal system is interfering with its activation. If, on the other hand, morning erections have also declined or disappeared, gradually, over the same time frame as waking difficulties, this pattern is a red flag for vasculogenic origin. The overnight vascular maintenance cycle is failing. That failure is systemic. Think of it like a pump that works when manually primed, but fails to run on its automatic cycle. If it fails during the automatic cycle, when nothing psychological is interfering, the fault is in the pump itself, not in the operator. The third dimension is exercise tolerance, and this is where the cardiac connection becomes most clinically direct. Erectile function requires a temporary surge in blood flow to the penile arteries. Physical exertion requires a sustained increase in blood flow to the coronary arteries, the skeletal muscles, and the pulmonary system. In a man with early-stage endothelial dysfunction and beginning coronary artery disease, physical exertion stress tests the cardiovascular system in exactly the same way that sexual arousal stress tests the penile vasculature. Men who are developing cardiovascular disease often notice reduced exercise tolerance before they notice chest symptoms. They tire more easily, they become breathless at lower intensities, they recover more slowly after moderate exertion. If your erectile difficulties are accompanied by any reduction in exercise tolerance over the same time frame, even subtle changes you might attribute to aging, the concurrent timing of these two changes is clinically significant and warrants cardiac investigation. A study from the University of Adelaide, tracking 1,709 men aged 55 to 80 over a 5-year observational period, found that men who reported both erectile dysfunction and reduced exercise tolerance simultaneously had a 4.2-fold higher rate of major adverse cardiac events than men who reported erectile dysfunction alone, 4.2 times. The combination of these two symptoms in the same man during the same time frame is not coincidence. It is a systemic vascular signal expressed in two locations at once. The fourth dimension is your cardiovascular risk profile, and I want to be specific about which risk factors most powerfully amplify the cardiac significance of erectile dysfunction. Hypertension is the single most important one. High blood pressure damages endothelial cells directly. The sheer stress of elevated pressure disrupts the cell-to-cell junctions that allow nitric oxide to be produced efficiently. A man with hypertension and erectile dysfunction is, by definition, a man with documented vascular stress and a potential early marker of vascular disease in one of the most sensitive arterial beds in the body. That combination demands cardiac evaluation. Type 2 diabetes amplifies the risk further. Elevated blood glucose glycates endothelial proteins, accelerating the dysfunction of the same cells responsible for both penile and coronary blood flow. A diabetic man with erectile dysfunction has a risk profile that most cardiologists would treat as an active cardiac investigation case, not a watchful waiting scenario. Smoking history compounds all of the above. The oxidative stress from tobacco directly depletes nitric oxide and accelerates endothelial aging by an estimated 10 years relative to non-smokers of the same chronological age. Think of each of these risk factors as a weight on one end of a scale. Erectile dysfunction alone tips the scale toward concern. Add hypertension, it tips further. Add diabetes, further still. Add smoking history, and the scale has moved decisively into territory that requires action, not monitoring. The question is not whether your erection problem is embarrassing. The question is, how many weights are on your scale? The fifth dimension, and the one that most directly tells you whether to escalate urgency, is symptom trajectory over the past 6 months. Stable erectile dysfunction that has not changed in character or severity over the past 6 months is a different clinical picture than erectile dysfunction that is actively worsening. Progression, increasing difficulty, declining firmness, reducing frequency of morning erections, reflects ongoing vascular deterioration. Active progression, combined with any of the cardiovascular risk factors above, is the clearest signal in the clinical picture that a cardiac workup should not wait for the next annual physical. It should happen at the next available appointment. A study from Cedars-Sinai Medical Center, following 820 men with newly diagnosed erectile dysfunction over a 2-year period, found that men whose ED progressed in severity during the first 12 months were 2.8 times more likely to experience a cardiovascular event in the following 24 months than men whose ED remained stable. Progression is the accelerant. If your symptoms are moving, not holding steady, that movement is data. Now let me give you the exact language to use at your next physician appointment, because I've seen too many men leave these conversations without the investigation they need, simply because they didn't know how to frame what they were experiencing. Say this: I've been experiencing gradually worsening erectile dysfunction over the past 12. My morning erections have also declined over the same period. I have 3. I'd like to discuss whether a cardiovascular workup is appropriate, and I'd like my endothelial function and coronary risk assessed, not just my testosterone. That single paragraph changes the conversation from a prescription discussion to a diagnostic one. Most physicians, hearing that framing, will order what needs to be ordered. The tests you want discussed include a fasting lipid panel, if not recent, a fasting glucose and HbA1c, a resting ECG, and, depending on your risk profile, either an exercise stress test or a coronary artery calcium score, a non-invasive imaging test that measures actual plaque burden in the coronary arteries and is one of the strongest predictors of future cardiac events available in outpatient medicine. Here is your complete action protocol. Tonight, honestly assess your erectile symptom pattern against the 5 dimensions I described: onset speed, morning erection status, exercise tolerance changes, cardiovascular risk factors, and 6-month trajectory. Write down your answers. This is your clinical summary. Starting tomorrow, if your assessment reveals gradual onset, declining morning erections, any exercise tolerance change, and 2 or more cardiovascular risk factors, call your physician's office and request an appointment specifically to discuss cardiovascular risk assessment in the context of erectile dysfunction. Use the language I gave you. Do not frame it as a sexual health visit. Frame it as a cardiovascular risk discussion. This week, if you do not have recent blood work, Request a fasting lipid panel, fasting glucose, and HbA1c at minimum. This month and ongoing. Regardless of your cardiac findings, implement the lifestyle behaviors that directly support endothelial function. Daily brisk walking for 25 minutes minimum, elimination of smoking if applicable, blood pressure management, and reduction of dietary saturated fat. These are not supplementary suggestions. They are the direct interventions that slow endothelial deterioration and, in some cases, partially reverse it. Track this specific marker: morning erection frequency and firmness, assessed honestly each week. Improvement in this marker is one of the earliest signs that endothelial function is responding to lifestyle intervention. Expect to see changes within 6 to 10 weeks of consistent behavioral modification. One final story. Martin, 67, came to me for what he described as a personal matter. He had been managing progressive erectile difficulties for 2 years, gradually worsening, morning erections essentially gone, and he mentioned almost incidentally that he'd stopped playing golf because the walking winded him more than it used to. He had hypertension, managed with medication. He had a 20-year smoking history, quit at 55. He had no chest symptoms whatsoever. I ran his 5-dimension assessment in our conversation and referred him for a coronary artery calcium score the same day. His score came back at 847, in the severe range, indicating extensive subclinical coronary artery disease. His cardiologist started him on aggressive medical therapy immediately. At his 6-month follow-up with me, he sat down and said something I've thought about many times since. I came in here to talk about something I was embarrassed about, and you sent me somewhere that told me my heart was in serious trouble. I had no idea at all. He is well. He is being managed. He came back to golf, slowly, carefully, with his cardiologist's clearance. But he came back. Gentlemen, here's what you need to understand. Erectile dysfunction is not always a sexual health problem. In a significant proportion of men over 55, it is a cardiovascular signal, the earliest, most sensitive warning your vascular system can produce, expressed through the smallest arteries in your body before the larger ones show detectable disease. The research is clear and compelling. Erectile dysfunction is associated with a 62% increased risk of heart attack, and men whose ED progresses actively over 12 months face nearly 3 times the cardiovascular event rate of men whose symptoms remain stable. We examined 5 diagnostic dimensions today: onset pattern, nocturnal erection status, exercise tolerance, cardiovascular risk profile, and 6-month symptom trajectory. Men who assess these dimensions honestly and act on what they find give themselves the chance that Martin had. The chance to know before the heart tells you in a way you can't ignore. Starting tonight, run your own assessment, write it down. And if the picture you see warrants a phone call tomorrow morning, make it. If this video prompted you to think about your symptoms differently, hit that like button and tell me in the comments, have you ever had a doctor connect your erectile health directly to your cardiovascular risk? Yes or no? That answer tells me something important about how this conversation is or isn't happening in exam rooms across the country. Subscribe to this channel because every week we cover the men's health connections that individual specialists leave undiscussed, and the ones that matter most after 55. Next week, I'm breaking down exactly what your PSA number means at every age after 50, including the specific rate of change that matters far more than the number itself, and what to say when your doctor tells you to just keep an eye on it. I'm Dr. Jocelyn. The most important health conversation you have this year might start with something you're embarrassed to mention. Don't let embarrassment cost you time you don't have.